Frontalis muscle, what do you actually need to know? Frontalis muscle is a thin sheet of muscle that extends from the gallia aponeurotica all the way down to the skin of the brows. From here down to here. It sits just in front of your frontal bone and it is responsible for elevation of your eyebrows. I've got too much toxin in my forehead, so I can't really demonstrate, but it is responsible for conveying that shocked or surprised appearance. If you understand the fact that it is the only muscle responsible for elevating your eyebrows, then you will understand how bad or good neuromodulator is done. A little bit about the anatomy. The muscle itself is about 1 to 2 millimeters thick, depending on sex and age. So typically it's about the same thickness as a piece of meat from a deli counter. Thin meat, that is. Its motor innervation is from the temporal branches of the facial nerve. And the blood supply is the supratrochlear and the supraorbital arteries. You may also be aware that the muscle itself has a bifurcation. So in some people, the bifurcation's right up the top, like you can see on my 5 head. On some people, it's right down here, so they have a really low bifurcation, and other people don't have a bifurcation at all. Why is neuromodulator so important and so popular for the frontalis muscle? Over time, as our skin integrity decreases, our poor skin is subject to the constant battering of facial expression. Neuromodulator is the perfect way to give your skin a little breather for around 3 to 4 months. By stopping that constant pushing upwards and damage to the skin, we create a smoother, softer playing field for everything else we do for our skin, including our skincare, microneedling, peels, etc. Now, although the frontalis muscle is probably the first one you learn as an injector on your courses, it's also commonly mistaken for being a really easy muscle to treat. And as a result, there's often a lot of mistakes made. So let's just talk about the do's and don'ts of treating the forehead itself. The first thing you learn as an injector is to not go too low on the forehead. Okay, so we're always encouraged to leave 1 to 2 centimeters distance above the brow. And what this will do is reduce the risk of us paralyzing the lower fibers, what we call the inferolateral or the inferomedial fibers of the frontalis muscle. As a result, that will stop that heaviness. So something you're never going to do as an injector, you are never going to inject in here, and you're never going to inject in here. That is what we call the danger zone, and it's usually the first thing people learn on a course. You're also not going to inject into these inferomedial fibers of the frontalis, okay? Because if we relax these, you're going to cause medial heaviness. What else are we going to do and what are we not going to do? When we inject the frontalis muscle, we are not going to inject deep. If your needle ever touches bone, you've gone too deep and you do not want to place toxin there. By injecting toxin beneath the muscle, we risk the toxin trickling down your bone and diffusing to areas we do not want it to affect. So it's safer to stay more superficial than too deep. But if you feel confident, an injection depth of around 2 to 3 millimeters is perfect in most people to hit the muscle belly. What we're also going to do is ensure we do our best to provide even distribution of toxin across the whole frontalis muscle. By doing that, we reduce the risk of any asymmetries at 2-week review. We're also going to reduce the risk of any excess muscular contraction. For example, ladder lines, where you've got excess pull in the corners. Okay, now we've discussed what to do and what not to do, let's discuss some of the most popular treatment approaches for the frontalis. And yes, before people come at me and say, oh, but everyone's different. Yes, everyone is different and you have to treat the individual in front of you. However, there are a number of standard treatment protocols which can yield good results for most people. But yes, always treat the person in front of you. If you notice someone has a slightly stronger right side, obviously put slightly more on that side. Treatment protocol number 1, and possibly the most published treatment protocol there is, using Allergan units, you would do a total dose of 20 units across the frontalis. 4 units, 4 units, 4 units, 4 units, 4 units. 5 injections of 4 units each, typically with a normal dilution that would be about 0.1 ml of solution, a total dose of 20 units. For most people, this yields really good consistent results. Second approach, and probably the one I use the most as a kind of default toxin treatment, would be 3 injections each side of the frontalis, either side of the bifurcation if it's present. Typically 2 to 3 units, so that would be 12 to 18 units in the frontalis. That is possibly the treatment pattern I use most in the frontalis, and depending on where the bifurcation is, I may add an extra 1 to 2 units at the top in the middle. And finally, a treatment pattern which more and more people are pushing towards now, which involves more injections but smaller dose per injection site. So typically 1 to 2 units per injection. Usually about 5 injection points per side. And again, if needed, a small aliquot in the middle where the bifurcation is. More and more injectors are preferring a treatment pattern like this, as it guarantees even distribution and you haven't overshot it in a certain area as you're sticking with smaller dosages. So that is everything I believe you need to know about treating the frontalis. If you found that useful, save it for your learning and feel free to drop me a DM if you have any questions.